lumbar puncture. Lumbar puncture is basically trying to take CSF out from a space called as the lumbar space. Okay, that is lumbar puncture. So when to do it, when not to do it. When do you need to do it in a spectrum is there is diagnostic and therapeutic means. But when we come to intensive care unit, it's usually diagnostic. Therapeutically, you don't do lumbar punctures in intensive care, very rarely. NPH patients, you cannot really diagnose on an ICU in the first place. Okay, an NPH patient is a person who's normal pressure hydrocephalus, is a person who is having problem in passing urine, who is imbalanced, who's not okay. He comes to you and he says, I'm not okay, I'm not okay. And he's coming to the OPD, you do a CT or an MRI, shows large ventricles. Then you call him, come, let's do an LP. Then you do the LP and make him walk again and see whether his balance gets better. So it's an OPD investigation when it comes to therapeutic tapping, which is removal of CSF from the lumbar space. Usually in the ICU, it's going to be diagnostic. Even before you go into what this lumbar puncture is all about, you should understand how much CSF is there in the body. So on an average, how much CSF is there in the body?
150.
Correct, 150 ml. 150 ml is the amount of CSF that you'll have in the body. On an average, how much are you producing per hour?
500.
Per hour? Per hour, you're producing somewhere around 24 ml per minute. 24 ml per minute. 0.4 ml per minute is the, so 24 ml per hour. You understand, now? So it's 0.4 ml per minute is the approximate amount of CSF that you're producing per minute. So in an hour, it is 24, 25 ml, not more than 24, 25 ml. This means to say why this is important for you to understand. Sometimes you have patients post-operatively with EVDs or external ventricular drains inside. They've got a drain that is lying inside the ventricle, and that is with a bag. So remember this, since the approximate amount that is coming out per hour is 24 ml, you can't drain 50 ml. You understand? पूरा chink हो जाएगा पूरा ventricle, सड़ जाएगा पूरा ventricle. समझ में आ रहा है? So 24, 25 ml is the maximum ml required, because otherwise what will happen, that CSF is important to buoy the brain, to keep the brain nice. If I keep on removing CSF, what is going to happen? The brain will settle down because it's no longer floating on that CSF. Since it's not floating on that CSF, if the brain settles down, the entire dura gets stretched, and that's why you get the headache. That might lead to dural separation and causing some hematomas also. So that's the reason that we don't want to remove excessive amount of CSF. Clear? So the amount of CSF per minute is minute coming out is 0.4 ml per minute, and so on an average hour it is 24 ml per hour that comes out. The CSF is ideally a very colorless and odorless fluid that comes out. It comes from the choroid plexus into the ventricle, from the ventricle to the aqueduct, from in Monroe, from in Lashka to the spinal canal. But the difference of pressure between the top and low is not too much. Okay, and that's why the whole differential, the entire pressure that is there inside your brain is somewhere around 20-25 centimeters of water, not more than that. That is the amount of pressure that is there inside the CSF, 20-25 centimeters of water. So which patients, so coming back to the question as to which patients from intensive care will require a lumbar puncture, diagnostic, mostly it would be diagnostic, and that's where your entire clinical skills comes to understand, do I do it now or do I wait for an imaging? Do I do it now or do I wait for an imaging? So let's take the example of a patient who comes in to the casualty and has had a seizure and a fever and an altered mental status now. Fever, altered mental status, comes to the casualty, has a seizure. Will you go for the LP or no? I put this patient again to you. You have a patient that comes in with fever. Can you get me a pen from there? Either pen. You have a patient that comes with fever, altered mental status, and a seizure. You have a patient that is immunocompromised with AMS, altered mental status. You have a patient with fever, altered mental status. You have a patient with fever with the presence of, say, a focal neurological deficit. So which of these patients you can do a LP? You have got many patients here. You've got patients with fever, altered mental status and a seizure. You have a immunocompromised status with altered mental status with fever. Fever being common, that's why you're suspecting meningitis and altered mental status. You have fever with altered mental status that is coming to you, and maybe neck stiffness. Let's put neck stiffness here. And you have fever, focal neurological deficit with photophobia here. Now tell me which of these patients will get a LP. What can you answer this? Which do you think?
The first patient.
The rest will not get an LP.
Since this patient has neck stiffness, so probably he has some sign of raised ICP. So we'll probably.
So you are saying neck stiffness, raised ICP, so I don't want to do LP. Okay, I got one answer from here. But which one you want to do?
The first patient.
First patient. LP. First patient you want to do. Those patients have fever, AMS and seizure, you want to do an LP. Anybody has a different answer? You can answer now because there is nothing wrong by doing anything right or wrong. You're not going to, but later on in exams you're going to be having a problem if you don't answer now. You have to use your intellect and try to answer this. All patients. So he says that all patients I'll try to do an LP.
Only second को छोड़ के बाकी तीनों.
इसको छोड़ के तो बाकी सब में LP करोगे.
Immunocompromised.
Okay. So he says immunocompromised status, altered mental status and fever. This is the only patient that will not do the LP. Whereas the rest everyone will do the LP. Anybody else?
I don't know.
Huh?
All patients.
All patients should do the LP. Okay, so
No,
let's answer this.
it's
Actually, you
only
answered
third
this in your
one.
PPT. So, but let me explain to you this properly because I don't think people have understood this. Because this is the most crux decision you have when you come with a patient. There are 1 minute. So now see the entire issue is we had these 4 places where we talked about. And I'm surprised that you didn't have the answer here. None of y'all had the answer. In fact, everybody were wrong. Everybody, not a single one, including you, were wrong. So all of these patients, I'll explain to you what the situation is from each patient. So now this is where decision making of intensive care comes in. This is where you as a doctor makes a difference. This is where you have to take a call as to what is to be done. Now, fever, altered mental status, and seizures. The moment you have a seizure coming in, this means to say that this patient may have a space-occupying lesion. That is the first thing that will come into your mind. Okay, the first thing. If a seizure comes in, first rule out space-occupying lesion. Okay, it may be abscess, maybe tumor, maybe whatever. So obviously, if there's a space-occupying lesion, I said we cannot go for an LP. Why we can't go? Because if there's a space-occupying lesion, the pressure on the top is different. The pressure down is very different. Suddenly, if you release the pressure from down, the pressure differential will change. When the pressure differential will change, there would be herniation from the top downwards, which will cause the patient to pass away and die. Clear? So, the entire game is to figure out whether I have space-occupying lesion. So, in this, you are very clear. If there's a seizure, there's a high chance that this patient can have a space-occupying lesion. If it's a space-occupying lesion, I will never do an LP over here. Clear? Am I clear on case number 1?
Yes.
Case number 1 is clear? Huh? Now case number 2. You have a patient of immunocompromised status, AMS and fever. Someone did answer that I don't want to do the LP here. Who answered no? Why?
Other reason भी हो सकता है. Immunosuppression में other infection, normal system infection भी हो सकता है.
No, that's not the answer. The answer again is veering around this part, which I said differential of pressure. We are worried about that. So what is the real reason why you're not doing this here? Because a patient who is immunocompromised can have a very high chance of having an abscess in the brain. Immunocompromised patient, renal transplant patient, he is some kind of patient, so he has a very high chance of having an abscess in the brain. Are you getting the point? So if he's got an abscess in the brain, again what is it? It is an SOL. Okay, not only that, immunocompromised patients are known to have, HIV patients are known to have lymphomas. The lymphoma may be in the brain. CNS lymphoma. It's a very known pathology when it comes to immunocompromised patients. Correct? So if you're an immunocompromised patient, the reason being you may have a SOL in the brain, which might be either a brain abscess or could be a lymphoma. You are getting the point now? So it's not related to other infections, related to the fact that yes, there may be a SOL over here. The third one, let's take this one. Fever, focal neurological deficit and photophobia. Now here what has happened, again you have a FND. A focal neurological deficit again indicates that there may be a space occupying lesion inside the brain. You understand? And so this also is a place where I will need a quick CT scan. But this is the only place where there's fever, altered mental status and photophobia, which is basically the only place where I can go directly into an LP. You understand? Because this does not indicate that there is a space occupying lesion. This only shows you that there is meningitis features, and which is the classical triad: fever, altered mental status and headache and neck stiffness. Correct, neck stiffness.
Meningitis.
Fever, headache and altered mental status is the triad for meningitis. Fever, headache and fever, headache, and altered mental status is a triad when it comes to this. Whereas neck stiffness, photophobia, and headache is a triad for meningismus. There's a difference. Meningitis is a disease. It's a disease where you can have fever, headache, and altered mental status. So any patient who comes with fever, headache, and altered mental status, meningitis unless proved otherwise, LP required. Okay? But meningismus is a completely different thing where you have meningeal irritation. Meningeal irritation is called meningismus, and meningismus will occur. Which are the characteristic findings of meningismus? Nuchal rigidity. That means neck stiffness. So in scientific terms, we call it nuchal rigidity. Why do they develop nuchal rigidity? No, the meninges are irritable. Meninges have got inflamed. Since meninges have got inflamed, the upper cervical nerves are passing from the same area. The upper cervical nerves are passing, so the body goes into a rigidity. So the neck stiffness comes inside. The body goes rigid. Anywhere in the body you have a peritonitis, it becomes rigid. The body goes into a rigidity. So the upper cervical nerves get irritated. Since the upper cervical nerves get irritated, because that's where your meninges are going from, you get neck stiffness. That doesn't mean that it is like this, it is flexion. Neck stiffness means difference in flexion. By doing this, we can't say there is nothing. There is nothing like horizontal movement. It's only flexion. Neck stiffness. The second thing you see is photophobia, meningismus sign. Photophobia. Why do you get photophobia? Similarly, when what is happening is when you are actually putting a pupil torch into the eye, it is going through the oculomotor nerve, going through all the tract and coming back, and then causing this. So that tract is irritable. That tract is irritable, and that's why they resist. The pain starts in over there. Trigeminal nerve is involved over there. The trigeminal nerve is a part of the entire pathway. Edinger, Westphal nucleus, and all those trigeminal nucleus. So what happens is trigeminal nerve is a part of it. So the moment you put a light, the trigeminal nerve, which is already irritable because of the meningitis, that causes more problem. That's why photophobia. A person does not want to take it, gets pain, trigeminal pain. You understand? So photophobia means you try to open eye, put the beam in the eye, and they are not allowing you to do that. That is photophobia. That's a sign of meningismus. That is meningismus. Meningeal irritation. Okay? Meningeal irritation. So photophobia is a part of it. Neck stiffness is a part of it, and headache is a part of it. Headache because meninges are involved. Clear on this? That is meningismus. Clear on this? What is meningismus? So there is a difference between meningitis and meningismus. Meningismus is a feature of meningeal irritation, whereas meningitis is when the meninges gets inflamed and causing that disease of a triad of fever, headache, and altered mental status. It's not a pentad, it's always a triad. Okay, and the triad is seen only in 40 to 50% of cases. It's not seen everywhere. You may have just fever, you may just have headache, you may just have altered mental status. Okay, clear on this? So now we are clear which patients I will do in LP and which I won't. Am I clear now?
Yes.
Am I clear? Everybody is clear? I would put all of these things. Which is the place where we will do it? Kedar?
Yeah, sir.
Which is the one?
Fever, and neck sickness.
This one is the only one to do in LP.
Yeah.
Because the rest, everything indicates some space occupying region. Okay?
Just in case if we do the scans and if there is no space of
Then we do the LP. So that's why we do the scan. We do the scan to figure out there is this or not. So in a case of bacterial meningitis, what is very important? Very important is to send blood cultures first. Sabse pehle. Most important is send the blood cultures ASAP. ASAP. Okay, so ASAP. That means patient comes in, even when the CT scan is getting ready, even when the CT scan is getting ready for going for a CT, for example, you have an FND, okay, you still send blood cultures first. Sabse pehle blood culture. It's very essential. You need to do the blood culture immediately. Then the next step is if we're going for a CT scan, okay, you know very well. Now, what is the problem in the CSF? The problem in the CSF is in the CSF now there are no complements, there is no immunoglobulins. ये सब नहीं है CSF में. अब जैसे body में होता है. In the vascular compartment you have immunoglobulin, you have T cells. There are a lot of other things are there. But the CSF does not have anything. Normal CSF WBC is 1, 2 like that. उसमें कुछ fighting power ही नहीं होता. तो उसमें bacteria multiply हो जाते हैं. You understand? Because there is nothing over there. Since there is nothing over there to fight the infection, the bacteria just multiplies. You are getting the point? Unlike in your vascular system, you have bacteria. It takes some time for it to get infected. Takes some time for it to get pneumonia. Time लगता है. इसमें क्या होता है? Multiplying rapidly. Essentially, even when you give the antibiotic, it goes down also very rapidly. You understand? When you give antibiotic, it goes down also very rapidly. So tomorrow, if I give an antibiotic and then do the LP, I will not get anything in the CSF. You getting the point? I will not get. and my yield of blood culture being positive also becomes extremely low. If I don't do a blood, if I give the antibiotic and then do the blood culture. So the first step for any doctor in the intensive care unit is, if you have something like this, is blood culture. First step. Okay, and then if by any chance you are in this category, a quick LP, and then the therapy. Right? Whereas in this case, what will be our, any of these cases, what will be our plan? Huh?
Scan.
What will be our plan? No. What will be our plan?
Rule out
Rule
as well.
Rule out space occupation.
Before that, if a patient comes to the
Blood culture.
first
Blood culture.
Correct. The first answer would be first blood culture.
Fever.
Even before the scan is being done, the first will be blood culture. Then will come the scan. If there is SOL, that's a different situation. But if there is no SOL, then the LP. Okay. But if this is going to take more than 1 hour, that is LP is going to take more than 1 hour, I will give the antibiotic. If it is going to be less than 1 hour, I will first give the antibiotic and then give the LP. Getting the point? Are you understanding what I am saying? I'll repeat this once more. Okay. If you have a clear case of fever, neck stiffness and headache or altered mental status, this category of patients, I will not do CT scan. I know for certain this is probably meningitis. I will send my blood culture, do my LP and give the antibiotic. Clear? Clear? Huh? And it is called as golden hour in meningitis. तो 1 घंटे के अंदर ये करना पड़ता है. 1 घंटे के अंदर क्या करना है? हमको ब्लड कल्चर करना है, LP, ठीक है. This is the first 1 hour, golden hour of meningitis. Clear on this? Whereas if you have everything like this, again it's a golden hour only. But in that golden hour, what are the 3 things that are coming in? Nidhi? Blood culture first, imaging, CT, LP. So in the first 1 hour, LP and then an antibiotic. But in the first 1 hour, if you are not able to get to LP, you don't wait to do the LP for a CSF sample. You give the antibiotic and then do the LP.
Yes.
Clear on this? So it's a 1 hour window. So as a doctor in the ICU, in the hospital, you should have that 1 hour window in your mind. Clear till now? Now the question comes: how to do the LP here? How to do the LP? So that's what we were thinking. So which are the LPs? So first thing is very important is where to do the LP. Can it be done in supine position or can it be done in propped up position? How do we do it? So anesthetists are very comfortable doing it in the propped up position. But this patient will not allow you. Altered mental status है, neck stiffness है, उसको prop up करेगा, उसको दर्द होगा. Very difficult. So usually these patients are done in the supine position. And we also do it in the supine position because you generally want to find the opening pressure. In the propped up position, the opening pressure needs a calculation and it may not be accurate. But in the supine position, the opening pressure becomes accurate. Now let's do how to do the supine. In the supine position, if you want to, you need 3 people. You can't have 1 person doing it. 3 people is required. 1 person who will ensure that the position is maintained. Okay. The second person is going to help you with all the devices, and you, the third person, is going to do this. Okay. 3 people are required in such cases to do the LP. Prior to the LP, a few things that I would think is, I have ruled out an SOL. First thing. Second thing, I have ruled out anticoagulation. Very important. Okay, so how much time do you need to wait for an anticoagulation before you actually go ahead for LP? Say for example, patient is on LMWH. How much time?
12 hours.
So it depends on whether the LMWH is therapeutic or diagnostic. It's not 12 hours. Okay, so you'll have to basically ask, is it diagnostic LMWH or is it therapeutic LMWH? So when somebody asks you LMWH, you'll ask, is it diagnostic or is it therapeutic? When it's a diagnostic diagnostic LMWH, DVT LMWH, it is 0.4 OD. Diagnostic, when I say DVT prophylaxis is 0.4, okay, or 0.6 of LMWH. And if it is therapeutic, it is 0.4 BD or 0.6 BD under LMWH. Clear on this? So you have to ask whether I am doing it for DVT prophylaxis or I am doing it for therapeutic purposes. Okay, when you ask for LMWH. If it is just for DVT prophylaxis, I have to wait for. If it's this, how much I have to wait for? Sorry? No, you have to wait for 12 hours. 12 hours. You have to wait for 12 hours. Very often you'll have patients who are at home, underwent a TKR, and then developed the meningitis because TKR got infected and that infection went into the brain and things like that have occurred, and that patient may be on LMWH for 1 month. These patients are on LMWH for 1 month. They're given 1 month of LMWH. Okay? When they're given 1 month of LMWH, you really cannot immediately do it. You must be. Hold on.
For therapeutic.
LMWH.
LMWH.
You just warm some water for me in my kettle. खाली पानी डाल दो, गर्म हो जाएगा. Where are we? LMW. So what did I say? When to stop. So if you are on diagnostic, DVT prophylaxis, it is given once a day. So you have to wait for 12 hours before do the LP. Clear on this? So clearly LP is out there. It comes after 12 hours. It doesn't come at the golden hour at all. Okay, it is not going to give you much information. Okay, then I will think of diagnostics, TNGS, MNGS, all of those things I will think of because I'm not going to get a diagnosis very quickly. Or everything will alter. Clear on this? Because I would have given the antibiotics and all. But if it's therapeutic, that means it's BD doses. It's these BD doses. I have to wait for 24 hours. So kind of LP is almost out. Okay. What if the patient is on warfarin? If the patient is on warfarin but the INR is less than 1.7 or 1.5, I will still want to do the LP. So in this window, if this patient has got warfarin on board, my next step over here will be immediate INR. Just 1 घंटे के अंदर I need the INR to come in because if it's less than 1.5, I still want to do the LP. If the patient is on warfarin, the picture completely changes if the patient is on novel oral anticoagulants like apixaban, rivaroxaban, edoxaban, where you have to wait for 3 days. Picture completely changes for 3 days. Okay? So if this patient is on rivaroxaban, apixaban or edoxaban, 3 days, so I can't do anything. 72 hours I have to wait before I do an LP. Unless I feel that no, I need to do it. For example, if this patient has got cryptococcal meningitis, when the patient has cryptococcal meningitis, the patient can die if you don't do a therapeutic LP. Why? Because in cryptococcal meningitis, the biggest problem is raised ICP. Patient dies because of raised ICP. He dies of coning. Okay, and the best way to reduce that ICP is by doing an LP and getting off the fluid. Clear on this? In cryptococcal meningitis. So if I am suspecting strongly a patient who's strongly HIV, and the patient is HIV and the patient is probably cryptococcal, already diagnosed cryptococcal. Patient is already diagnosed cryptococcal, and unfortunately, patient has had a history of atrial fibrillation as in on warfarin, or his patient is on warfarin. Say for example, let's take the example that the patient is on warfarin. Patient is having HIV, and because of which he developed cryptococcal meningitis. Now he's come to you with a strong headache. Our suspicion is what? Cryptococcal meningitis induced raised ICP. Patient can cone and die. But patient is on warfarin. What do? I will reverse the warfarin. Not with vitamin K, with prothrombin complex concentration. With PCC, octoplex. I'll reverse the octoplex and do the LP because there it is therapeutic LP. You understand? You understand what I'm saying? So that's where I will use it. So if it's therapy,
INR अगर less than 1.5 है तो reverse करने की जरूरत नहीं.
warfarin अगर है और INR high है, but I want to do the LP. No, why do I want to do the LP? Because I have to remove CSF. You understand? So that stage maybe I will reverse it and do the LP. Clear on this? Clear?
How will come to know that patient is having cryptococcal meningitis?
Patient normally has a diagnosis. Such patients have an IVM, and patient is Shailesh. We have a patient who's already here. He's been here with us for a very long time. He comes regularly, and he's also. This is exactly the scenario. He has atrial fibrillation. He's on Eliquis, and he's on Eliquis twice a day. Okay, and he comes in from and he's HIV positive, and we have diagnosed him as cryptococcus, and cryptococcal meningitis doesn't go only. He's on lifelong flu cytosine. He's on that medicine since ages now. 3 saal se I know him, 3-4 years now. He's on that medicine. Okay, he calls up in the middle and he says, "I'm having headache." The moment he has headache, the only thing we can do in this case is to put a CSF and remove out fluid. So he comes to us with that tremendous headache. Now it doesn't come to us because it's expensive. He goes to another hospital, but we know what to do. He goes to the other hospital, he gets a reversal, and he gets that LP done. You understand? This is what he does. He comes regularly, cryptococcal. So they are normally diagnosed. Clear? Any other questions here? When to do the LP? Golden hour?
So for therapeutic tapping, how much maximum or minimum
What will it be?
25 ml.
25.
Okay, no, 25 ml. Clear? No, because you cannot do more than that because the approximate is 0.4 ml per minute. Though people have to have 30 ml and 40 ml also, because ventricles are big and dilated, so there's lot of CSF inside. It's no longer 150 ml. 20% are lying in the ventricle and 80% is supposed to be lying in the CSF spinal space. Okay, but many times what happens is this fraction becomes very high. It becomes 40-50% and this reduces. Okay, that time you may want to, because the ventricles are dilated or not, they might give 30 ml, 35 ml also. But that is all a titration once you are in NPH. It's not something that you do otherwise. It's a titration. For the first time when they do, it's always 25 ml. Because you understand, because 25 ml se upar, the production is not going. Clear? Now LP. So how do you do the LP? So now we've understood that we want to do the LP in such cases. And how to do the LP? So the LP will be done in the supine position. 3 people are there to help you out. Okay, to do this. Usually, when you're doing the LP, don't stand and do the LP. Get the patient in on the bed. The bed should be at the level of your eye. It should be at the level. The bed should be at the level of your umbilicus, and you are supposed to sit in front. And when the patient is facing that way, and patient is supine, and you are sitting on the back of the patient. This is how it's supposed to be. Okay, you're supposed to be sitting on the back of the patient because it's going to take time. You cannot stand and do it. It's going to take time. So sit and make yourself comfortable first. The position, very important. So when you're in the position, the spine should be parallel to the bed. The spine of the patient should be parallel to the bed. It cannot be abnormal. It cannot be upper and niche. It cannot be this way. It cannot be this way. It cannot be head low. It has to be in parallel. Why it has to be in parallel? Because if I want to find opening pressure, it is going to be suitable only when it's going to be right only when you're in parallel to the bed. It has to be parallel. Okay. The shoulder blades have to be perpendicular. The shoulder blades cannot be this way or that way. The shoulder blades have to be perpendicular. The maximum prominence as you move downwards towards the iliac or pubic bone, okay, is the iliac crest. The maximum prominence that you feel. The iliac crest corresponds to L4 level, spinous process. Okay, that's called the Tuffier line, or also called the intercristal line. Clear? So you have the patient in this position. You are supposed to curl like a cat. That means the knee chest position. That means the head is slightly flexed and the knee is also flexed onto the abdomen. The knee has to be flexed onto the abdomen. What does that do? It opens the spinous space. It opens the spinous spaces. Since it opens the spinous spaces, you can now enter into the spinous space properly. Clear? Clear on this? Clear on this? The position is clear? That doesn't mean you press it hard. Remember this, when you're doing opening pressure, I can't have that position. If I want to figure out opening pressure, the patient's neck cannot be excessively flexed, nor can be the hips flexed. Because if that occurs, then the pressure will be transmitted to the spinal canal and the pressures will change. You're clear? So I have to minimally flex to a knee chest position. I minimally flex the neck, but when I'm actually wanting to, once I've entered inside, I have to open up the legs, open up the neck, so that I can monitor the pressure if I want to monitor the pressure. So when I can't monitor the pressure if the patient is curled like a cat. Simple? Simple on this? If you're going to do it that way and monitor pressure, you're wrong, because the pressure will go up. Clear on this? Clear on this till now? Position. The intercristal line is where you're going to look at. That is between the intercristal, the space. And when you're cleaning, you have to clean in such a way that you go inside to outside. Always. Never like this. Never like this. It's always inside to outside. So inside, outside. It has to go like that. It has to go like that. There's no other method. Okay, there's no other method. It has to be cleaned at least 3 times. So normally you have to have 6 gauze pieces. One on your sponge holding forceps. And then 1, 2, 3, 4, and 5th inside your palm. 6 gauze pieces you should have. So you're holding it like that. Okay, 6 gauze pieces. Clear on this? So 5 here, 1 on my sponge holder. Clear? So 1, 2, 3 times you have to do it properly. 3 times you have to do it properly. 3 times you're going round. Then the last 2 is very important. The last 2 is absolutely sterile. It has to be. Last 2, absolutely sterile. You're going up to the scapula, up to the tip of the scapula, and down up to the needle cleft, up to the cleft, gluteal cleft. You're going up to the gluteal cleft. So it has to be done in such a way that you're reaching all through. If you're going to use it, if you're going to use only 2 gauze pieces, it is not right. 6 gauze pieces. Always 6. Always 6. That is the amount of thing you must do, because everything will go haywire otherwise. Okay? Clear till now? Then you put the whole towel there. Make yourself comfortable. keep the spinal needle either on the bed or on a table. Ideally, it should be on a table. Ideally, the spinal needle should be on a table, and you should have how many tubes?
Sample container. Sample container.
How many tubes you require? You require vacuotiners, right? You need vacuotiners. How many? Need 4.
4, yeah.
Always you need 4. Always and always you need 4. And I will explain to you how, why, and why. When. Okay, 4. Clear? Am I clear till now? Which is the needle you'll use? Twinkies? Anyone else? Anyone else? So you just explained there are 2 kinds of needles. The 2 kinds of needles that you have is Whitaker Sprott, Whitaker or Sprott, and the other one was Twinkie. The Whitaker and the Sprott needles were atraumatic needles, whereas the Twinkie needle is a traumatic cutting edge bevel needle. Cutting edge bevel means the bevel is also cutting. जो bevel है, the bevel which is there like that, the bevel is also having a cutting tip. Side is also cutting. So Twinkie is a traumatic needle, whereas the Whitaker and the Sprott is a atraumatic needle. So ideally, which will require? Ideally, the number I'll require, the one I'll require is atraumatic. That is the Whitaker or the Sprott needle. Unfortunately, worldwide, across tertiary referral centers and across the world, Twinkie is what is used. Unfortunately, okay, the cutting edge is used. So the cutting one is used. All through. It is, I don't know for what reason, but if you ask in guidelines which is the best needle, it is the Whitaker Sprott needle, which is atraumatic. Okay, unfortunately, across the world, for some reason, it is the Twinkie. And what we use here is the Twinkie needle. What we use in our hospital is the Twinkie needle. It will be written on it. BD Twinkie. It will be written on it. BD Twinkie. Okay, it will be written on the needles. Clear? Now the question is the number. Which is the number you use? Which is the number you use? And why am I asking you this question? Because the larger number, the smaller number is the larger sizes. So 20 will be large, 21 will be smaller, 22 will be even smaller, 24 will be smaller, 27 will be even smallest. Okay. The reason why we are doing this is because we want a sample. And we also don't want the CSF to come out in such a force that it causes huge amount of drop and also cause headache and does not heal. Okay. So that's why it has to be a mix between having the sample coming in quickly and at the same time ensuring that they don't create such a big puncture that it doesn't heal and keeps on leaking the CSF. And that's why the right number would be 22. The right number that you will probably use will be 22 Twinkie needle. Okay? So if you're asking for a LP needle, 22 Twinkie needle is the most safest needle that you can use per se for a diagnostic lumbar puncture. Okay? Though sometimes it does happen that you don't get it, so you want to change the needle to a 20 gauge. But usually it should be a 22 gauge needle, Twinkie BD set needle that we will use for LP. Clear? Clear on this? Until now, am I clear? Okay, now we have put the patient in that curling cat position, and you have found the intercostal distance. You have drawn an imaginary line, and then you palpate the spine. Above the imaginary line, you are at L3. That's the interspace you are, L3, L4 interspace. That is where L4 is where the spine comes in. The intercostal line comes at L4 spinous process. Above that, you are at L3, L4. Okay? You want to actually do the spinal tap at the L3, L4 level. And why is that so? Because, why is that so? Anybody?
Spinal cord ends at L1.
So, what why L3? Do L2. No, so there is a conus medullaris that comes. The conus medullaris comes after L1, and that actually goes outwards. It doesn't go like that. It goes outwards. So conus medullaris is there at the end. They are nerve roots at the end of the day. Okay, but they go outwards. So the safest place where you don't have all these structures is somewhere at L3, L4. L1 is spinal cord ends, but L3, L4 is where probably you have to do the spinal tap so that you avoid all these major structures. Clear on this? Classically, it is between L2, L3, L3, L4 that we do the spinal tap. Clear on this? Clear? Now the question is, when you do the spinal tap, what you should think when you're doing the spinal tap is your feel is very essential. Your feel of what you're feeling. So you should be able to feel skin and subcutaneous tissue. You should be feeling the supraspinatus ligament, then the ligament of flavum, then the infraspinatus ligament. Then the first pop you hear is epidural space. First pop that you feel, you are going like as though you're going through a banana or going through a potato actually. The moment you go through a potato, the moment you feel the first pop, that is epidural space. So you should be certain this is epidural space. So since you should be certain that you're in epidural space, you will take off the what do you call that, the stylet inside and see whether your truly in the epidural space. If there is no CSF coming, you are probably in the epidural space, because what has happened? You have gone through skin, subacute, supraspinatus, ligamentum flavum, infraspinatus. Till that time, there is no change only in the way you are going in. The moment you have reached the infraspinatus ligament and punctured that place, you are in the epidural space. Clear on this? The moment you get that pop when you are going inside, that pop is the epidural space. You are removing the stylet just to be certain that you are not in the spinal space. Clear on this? You are just removing the needle so that you are sure that you are not in the spinal space. Then after that, you again go slowly inside, because the next thing is puncturing the dura. Okay? The moment you puncture the dura, that's the second pop. When the second pop comes in, you remove the stylet and you see the CSF coming out. Clear? Any doubts? Any doubts? And this can come only when you do it. And actually, you should take a spinal needle and practice at home with a potato. It's really the way it should be done. You'll actually find out exactly कैसा होता है. Okay, you pass it and tuck करके बाहर निकलता. From the potato it comes out. You know, oh, this is where it is. That pop is what you can feel. You have to be able to feel it, because at the end of the day you are doing this process without ultrasound guidance. That's why you should know how to look at it. Clear on this? Clear? The feel is completely very important here. So once you get the CSF, the next thing is I want to measure the pressures. So unless I have a calibrated manometer, a calibrated glass manometer, I can't check CSF pressure. First of all, I can't check CSF pressure unless I have a calibrated glass manometer. Now, what is a calibrated glass manometer? It's a thin tube which is calibrated for CSF analysis. It's calibrated for CSF in centimeters are marked on it. It has got an end which gets stuck to the needle. It gets stuck to the needle. Okay, it's like this. So the moment you get the CSF, you attach this spigot over there, and there's this tube that is there, the straight manometer. Now what happens is the CSF starts coming from here, and it goes into this space. It keeps on rising, and it will oscillate, rising, oscillate, rising, oscillate, till it reaches a time when it stops rising but keeps oscillating. Till it reaches a time when it stops rising but it keeps oscillating, because you're breathing. Since you're breathing the respiration, there will be small changes in the meniscus. Then you measure the meniscus, that is your CSF pressure. Clear? Your CSF pressure. Many times what does happen is, if you're doing for cryptococcal meningitis, when you are having cryptococcosis where there is raised ICP, it will come out as a spurt. When it comes out as a spurt, you can be, before even putting the manometer, you can at least judge that maybe there is raised ICP. If it comes out in small dot, just small, obviously there is no raised ICP. Obviously there is no raised ICP. Clear on this? So very clearly, by just looking at it, you can know whether very high pressures or very low pressures, but you can't do anything in the middle. You get the point? To know what is there in the middle, to know whether it is 20 or it is 15 or it is 16 or it is 27 or 30. When it is 40 and all, I can see, because it will spurt. But when it is 25 which is higher, 27 which is higher, you still cannot find out unless you use a manometer. Clear? Am I clear on opening pressure? Clear on opening pressure? There is no other way you can do opening pressure. There is no other way. But yes, when you're doing the CSF and you find gush coming out, like in soft, it's coming out, like a tube, it's coming out. In spurt, it's spurting out. You can be certain that the pressures are high. How high, what, and why is this important to know the pressures? It's important to know the pressures because if you want to find out the cerebral perfusion pressure, it's MAP minus ICP. You understand? Cerebral perfusion pressure is equal to MAP minus ICP. And this, since I want to maintain my cerebral pressure at 65, my mean arterial pressure will be 65 plus ICP. So if my ICP is high, 65 plus say 30, I need to maintain my MAP at 95. Are you getting the point? So on an average, if you're putting the CSF and now you find high pressures, please assume that it is more than 25 at least. So the MAP will be higher than 90. Are you getting the point? 85, 90 तो रहना ही चाहिए MAP हमारा अगर वो pressure high रहेगा. So it's so important for you as a doctor on the bedside to understand this. Because if you do not give that high pressure to this patient, the cerebral perfusion pressure will go down and patient will develop other problems. Clear? Clear? Till now clear? Till now clear? The first step. We have just reached the first step. Okay. There is the first step. Now, the moment this starts happening, the CSF starts coming out. When the CSF starts coming out, with very sterile technique, you have to connect the CSF into 4 tubes. Now, the order in which you collect is very essential. The order in which you collect is very essential. Okay, what is the order? In the first tube, you will have proteins and glucose. In the first tube, it's always proteins and glucose. Okay? Huh? In the second tube, you'll always have gram stain microbiology. Huh? In the third tube, you'll have cytology. And in the fourth tube, you will have others. Anything else in the others. Fungal stain हो गया, AFB हो गया, क्या क्या हो गया वो सब उधर आएगा. ठीक है? समझ में आ रहा है? It has to be in this order. You cannot change the order. So tube 1, tube 2, tube 3, tube 4 ऐसा करके बोलना है. Tube 1, why is it so? Any idea? Any idea why you want to do it like this? Yes, any idea? Why? Because what is going to happen is when you are first putting the CSF, when you are doing the LP, there is a high possibility you will have contamination coming from the first, from your first thing. We don't want to avoid the contamination. Okay, so the first sample जो रहता है 4-5-6 ml का जो है वो protein और glucose में हमको contamination फर्क नहीं पड़ रहा. The new sample that's come all very clean, no?
Yeah.
The new sample. So then I took my gram stain and culture over here. ठीक है? And then cytology because that's my least of my problems over here. And then others. 4 tubes, why is it essential? Why 4 tubes? Even if there is nothing others, you still take 4 tubes.
Extra sample.
Sorry?
Extra sample.
One extra sample, second. If you are bleeding, so for example, you put a LP inside, and you have these 4 tubes. Okay. If here it is very red and here it is very less red, what does this mean? That it is a traumatic tap. Don't worry about it.
Yes. It's gone.
You know, you don't worry, it's a traumatic tap. Okay, but if it is same color here and same color here, okay, it means that boss there is some bleeding happening inside.
Yeah.
You know, there's some bleeding happening inside. Getting the point?
Yes.
It may be suburb, not everything.
SH. Yeah.
It may be SH. You getting the point? Clear on this? Am I clear on this? That's why, irrespective of what you're sending, 4 tube लेना जरूरी है. एक बार blood आके नो कैसा है, ठीक है? Clear on this? Now here, say you have blood. Let's take the example you have blood. So at that time you have to adjust the WBCs for that blood because blood आ रहा है ना तो blood में तो WBC भी होता है. ठीक है, blood आ रहा है, RBC भी है, WBC भी है. तुमने अगर वो CSF को जाके सेल काउंट कर लिया तो उसमें WBC आ जाएगा क्योंकि उसमें blood आया है ना. So what do you do in that case? In that case you have to adjust the WBC for the RBCs. So 1000 RBCs is equal to 1 WBC. 1000 RBC is equal to 1 WBC. There are various formulas, 500 to 1000. There's another formula where you do CSF RBC upon CSF WBC divided by blood RBC divided by blood WBC. This is another formula. This is called as CSF index. Okay. CSF index. CSF RBC divided by CSF WBC divided by blood RBC divided by blood WBC. Clear on this? This is CSF index. If this is more than 1, then the cells are high. Then the WBC cells are high. समझ में आ रहा है? हाँ, the cells, WBC cells are high. This means this is one index, but importantly, another important thing over here is the simple thing is to actually do this one. But you should know what this index is about. ठीक है? Clear on this? The moment you do the CSF, the same time you have to do a blood glucose. Okay. Now what you should understand in this is that when you're doing a blood glucose, the blood glucose has, if it's less than 40% that you're getting in the CSF, it means there is some element of infection. Clear on this? Some element of infection exists if the WBC, if the CSF glucose is 40% lesser than the blood glucose. Now here there's a small caveat. What you must see is also blood glucose is not widely fluctuating. If your blood glucose is 500 and then 200 and then 100 and then you're doing it at the time when the 200 coming in आधे घंटे के अंदर समझो तुम्हारा 500 था और आधे घंटे में तुम्हारा 100 हो गया और तुमने तभी CSF किया. It takes time for that blood to approximate inside. Are you getting the point? ये 100 से 500 अगर हो गया और ये तुमने तभी CSF कर लिया. If your blood glucose is steady for 30 minutes, 1 hour, that is the time. The 30 minutes, that is the time you should do it. Means अगर तुम्हारा पेशेंट शुगर 400 के साथ आता है तुम इंसुलिन पे भागो नहीं. अगर the practical aspect of this is, if the person comes in with meningitis, you're thinking it is meningitis and you're going to an LP, you found the sugar to be 400, don't start the insulin, which is a mistake that will happen because you're doing the LP here. You understand? And then तुम जब ये LP करने को जा रहे हो तभी तुम्हारा शुगर जो which is 400 has become 200, but nothing has happened to the CSF because it takes 50 minutes for the CSF to approximate. Are you getting the point? Then your ratio changes. You understanding? Your ratio changes. You understand what I'm saying? Huh? So don't put the insulin. Nothing going to happen. You getting the point? Do the LP first. Look at the sugar at that time. Compare it to the CSF sugar, and then go ahead. Then you start the insulin. You are getting the point? समझ में आ रहा तुम लोग क्या बोल रहा हूँ मैं? Because it takes time for the CSF glucose to change after the blood glucose has changed, almost 30-40 minutes. Clear on this? It's a mistake that happens very often. You are on insulin, the sugars were very high, and then you decide to do an LP, sugars have suddenly gone down, and then you have done the LP at that moment, it has not approximated, and your values don't come right. Clear? And that happens in emergency rooms very often. Patient comes in, you have 500 sugars, चलो इंसुलिन दे दो, 5 यूनिट्स इंसुलिन दे दो, चलो LP के लिए प्लान करो. अभी तुमने इंसुलिन दे दिया है, तुम्हारा शुगर चेंज हो गया, लेकिन तुम्हारा CSF शुगर चेंज नहीं हुआ है, तो तुम्हारा रेशियो बिगड़ गया. Are you getting the point? Getting the point? Because insulin will work quickly. Clear? Am I clear till now? Clear? On which sample, how, when, why? Clear? Any questions till now? Any questions till now?
Samples like per tube, how many samples you have to collect?
How much?
How much?
5 to 6 ml. We don't need more than that.
Per
तो सोच ना, you have 4 tubes. You have total 24 ml. बराबर ना? Maximum तुम 5 to 6 ही ले सकते हो ना? Are you understanding this? तुम्हारे पास खाली 24 ml है. 0.4 ml per minute. So if it's 0.4 ml per minute that's coming in 1 hour 24 ml I can remove max. ठीक है? तो मैं अभी निकाल रहा हूँ. क्यों मैं 25 से ऊपर निकालूं? तो maximum 5 ml per tube तो 20 ml निकल जाएगा. Are you getting the point? Simple mathematics, average mathematics. Clear? So when you're removing the CSF, my estimate is, is it water-like? Is it colored? Is it turbid? Once it's turbid, what does it mean? What does it mean? What is your thinking? If it's turbid, means what? What is the meaning of turbid? Means what?
Purulent.
How do you know? Purulent is different. Turbid is different. Turbid means
transparent.
that means if you take a paper and keep the tube in the front, you can't read it. If you take the tube and you keep it, so you have to check it. You yourself have to check it. You take a paper and try to read across the tube. If you can read across the tube, means it's not turbid. If you cannot read across the tube, it's turbid. If it's turbid, what is your thinking? What is the problem inside? If it's turbid, means there is high protein. Very high protein. Okay, there is very high protein. That's why it's turbid. Okay. If it's pus, means it's bacteria. If it's pus, if it's pussy, yellow color, it is whatever, pus type, thick, it is pus. You getting the point? If it's turbid means it's high protein. If you let it leave and it develops a cobweb like layer on the top, a whitish cobweb like layer on top, then it is TB. Very rarely we find cobweb. Cobweb, who will tell you? They will call you from the laboratory. You will not see it. It takes time for the cobweb to form. So the laboratory will call you and say, "Arey cobweb dikh raha hai isme." Clear? The question is, what are the investigations we need to send for this and that? This is the basic. This is the basic about LP. Clear? Any questions on lumbar puncture? Any questions?
सर जब needle अपन insert करते हैं तो bevel आपका
Upwards. Bevel is first upwards like this. When I'm going inside, the bevel is upwards, and then once I reach inside, I turn it like this.
Upward means on cranial side or
No.
just
See, patient is
upward?
lying in front of me. Bevel is this one. Bevel is this one, means it's upwards. Opening is upwards. Okay. I'm going like this inside. And the moment I reach inside, I have found my second pop. I turn it this way. I turn it this way, open my slit, so it will come from here. So every time I'm opening my slit, I'm turning it this way.
But sitting position में है तो
Sitting position में, also you go like that only. Why do you want to go like that? Because you've got a cutting tip.
Cutting tip.
So what happens?
If you do vertical, the ulta way, that will cause more injury to the dura.
Why not only dura? All the fibers are vertical.
Yeah.
Everything, yeah.
Since all the fibers are vertical like this, I want to split. I don't want to cut.
Cut, yeah.
That's why I'm going like this. समझ में आ रहा है? If I go like this, I'll cut.
Yeah.
Get the point? That's why you go this way. You go absolutely this way inside and then turn it like this. And there is a small indicator on the Quincke needle which tells you that which side is the bevel. On the Quincke needle, there's a small plastic on it which tells you that this is where the bevel lies. So you must be able to go inside, turn it, open, and see whether the CSF is inside. Any other questions on LP?
So while removing it also we do the same way so that it doesn't cut.
Yes. While rooming also we turn it back and take it outside. Because if you cut, you will create a rent. If you create a rent, there will be CSF coming out. If the CSF going to come out regularly, what is going to happen?
Ventricles will collapse.
The patient will get headache, no?
Yeah.
The post-dural puncture headache does not come otherwise. It comes because there is more of CSF leak. Now, if you cut the brain, there's not going to be any problem. But if you stretch the dura, there's going to be pain. If you cut the brain, tomorrow I open the skull and cut the brain, there will be no pain to the patient. The patient gets the pain when the dura is stretched. When the dura is stretched. Now imagine the brain is lying inside the dura. Okay, the brain is lying inside the dura. And you have done a CSF. And there is a lot of fluid coming out from down. Fluid is coming out. So what is going to happen? Slowly the brain will go down. What is happening? The dura is fixed on top. Since the brain is going down, the dura gets stretched. And the stretch causes the pain. Are you getting the point? Dural stretch causes pain. So a post-dural puncture headache comes only when the CSF is leaking excessively. When the CSF leaks excessively, you will get post-dural puncture headache. And that is the reason that people say after the LP, keep the patient supine. Supine रखने से क्या होगा? At least वो CSF ऊपर की तरफ जाएगा. It will not be completely coming down. ऐसा propped up रखेगा तो obviously थोड़ा ज़्यादा CSF निकलेगा ना. Propped up. But that's not the point. The point is doing the procedure properly. If you do the procedure properly, angling the bevel properly, ensuring that you're taking one nick coming outside immediately, nothing will happen. Taking the right number needle, pure post-dural puncture will not occur. Okay, if it occurs, the only thing is, what is the only thing we can do in such cases? Why hydration? Because that will prevent so much of fluid coming out. Will take care of that. That's why hydration. Number one. Second, caffeine may help as a headache reliever. Third, abdominal belt. Abdominal belt. Because what will happen? Abdominal belt लगा से, it will be like your नीचे position, no? Abdominal belt लगाएगा तो क्या होगा? Pressure epidural में जाएगा, पीछे जाएगा, तो उतना CSF leak नहीं होगा. Pressure differential change हो जाएगा. The pressure differential between the brain and the spine will change. So that's why abdominal belt. And fourth, final thing you can do in such cases, even if after 1 or 2 days patient is not improving, is to actually do something called as patch, blood patch. That means they remove the blood and seal the dura. You remove the patient's blood and block the dural opening. Go in the same place and inject that blood. Okay? That's called patch. Okay, but very rarely, I've done only one patch in my entire career. Okay, very rarely we've been able to normally manage with usual medicines. Okay? Any questions on LP now? Any questions on LP?